Hi everyone, I'm Yash, as you all know. Today we are going to discuss upon shoulder injuries in swimmers. Uh, I'm not going to. It basically is a very vast topic, so it's not possible for us to understand all the injuries in a span of say hour and a half. So I'm just going to highlight a few major injuries which come across in our professional swimming, and also I would like to use this opportunity in terms of explaining a bit of anatomy and biomechanics, because I feel that there is no point in me talking about injuries if you don't understand the basic functioning of the joints. So and I think considering the audience, most of y'all would not have seen the biomechanics and how the shoulder joint as a ball and socket joint and the muscles involved together work. So that is very essential. Once you all have realized how the bone and the muscles coordinate in terms of developing a movement, it'll become very easy for you to understand and relate to the injuries that occur. So there's no point me talking about the injuries if you all don't completely understand how things function over the shoulder. So I'm going to have a small presentation on a video of a shoulder mechanics and the anatomy also. I hope you all understand a bit of it. Obviously, it's going to be a crash course. We've invested 10 years of our lives reading books, and as we are still reading, but hopefully in 10 minutes, you all will have a brief idea in terms of how shoulder works. And basically, we're going to focus on the rotator cuff muscles. You all would have heard a lot from physios like me that this is a rotator cuff injury. So that is one of the major area where the injury occurs. And the other thing which we are going to focus on is a swimmer shoulder. So these are the two primary injuries which are found in 90% of the cases when it comes to shoulder pertaining to swimmers. So we'll try to look into the biomechanics, the anatomy, and then slowly I will explain you how what's the process in terms of how we go about making the assessments, and I'll try my best to explain you in simple terms what happens basically with those injuries, what are the structures which are involved, and what you need to do. Okay, let's move on. So, simple. I think someone's audio is on. If you could just please put yourself on mute, will be great. Thank you. Uh, Introduction. So, swimming is a very technical sport, and swimming fast is a highly skilled activity. Obviously, you all would know you need to put in years and years of hard work into mastering a certain stroke. There would be a lot of technique correction from your coaches. You have to understand the pattern right, and obviously execution at the end of the day. So injuries can be related to technique flaws. So essentially, if the technique is not ideal and if it's not correct, then what happens is you will compensate from some other area. So if you are not pushing in the ideal manner, something else will kick in, and probably that will have an adverse effect down the line. So usually what happens, it's not a sudden onset. It is something which starts at a certain stage and slowly progresses on to getting a little bit more complex and troublesome at some other point. So if you are saying that I have a shoulder injury right now and I'm not able to move, there are less chances that it has happened at that moment. It has already happened way earlier in the stage, but it has slowly reached a point where you cannot handle it. The threshold has reached. Okay. So shoulder is the most common injury. Around 45 to 90% of swimmers have some sort of shoulder injury. 31% of professional swimmers have opted out from their training or competition because of the shoulder issues. Now, the other important thing is that when it comes to swimming, water is nearly 800 times denser than air. So the drag forces, which all coaches would have explained, play a very important role. And if the mechanics are not right, then the drag forces will have a huge impact in creating some sort of a trauma over your shoulder, and which with time may aggravate, causing to an injury and leading you to not be able to participate in a certain competition or your training session. So It's very different from air. The water basically has a very, very huge impact when it comes to shoulder. So a clear pathomechanic diagnosis is often difficult to achieve. The whole kinetic chain seems to be involved with multiple extrinsic and intrinsic contributors. So essentially what I'm trying to explain over here is that it is rarely one structure which you can easily pinpoint that, oh, you came with a shoulder pain, I can say, oh, this, okay, this is. We have to look the shoulder holistically. We have to check your neck, we have to check your back, we have to check your core, we have to check a lot of other things. And that is what essentially means kinetic chain. So the issue might be at the shoulder, but the cause to why it has led to that kind of a situation rests at several other areas apart from the shoulder. So in simple terms, if you say that, God forbid, if somebody was hit and you've fell down from bike or something, there's a definite trauma. But what happens in swimming, it's not a contact sport. Most of it is intrinsic, things which are happening from within. You're working, there is a lot of micro trauma happening at the shoulder joint, a lot of overuse happening. So most of it happens from within. So if your kinetic chain, essentially the biomechanics, if it's not ideal, then it leads to a lot of complex shoulder issues. So I cannot pinpoint the shoulder. I will be able to pinpoint the shoulder, but issue, but it is rarely singular in nature. There are always multiple factors involved, which adds fuel to the fire. So when it comes to my management, I cannot just say, okay, do this. I have to give you a lot of, say, probably thoracic exercises, neck exercises, back exercises, core exercises to treat that shoulder. So it is all interlinked. Risk factors, what adds fuel to the fire? So if there is a sudden increase in training volume, say if you've been on a holiday and then you suddenly start training at full intensity, then obviously it might have some adverse effect. Mileage, all this is research based and statistically shown that if you swimming for more than 35 Ks a week or more than 15 hours, then you have a higher risk factor of having a shoulder issue. Unilateral breathing pattern, technical flaws which I've already explained. History of shoulder injuries. If you've had a shoulder injury in the past, then you have more chances of getting it again because you have developed a certain pattern in terms of movement. So if you've got a shoulder injury in the past, doesn't mean that you have to be scared that it is going to happen again, but you need to be more cautious. And this is the point where you need to understand why it happened in the first place. So if you regularly take care of those factors that have led to that injury in the past, then you have less chances of having that injury again, relapse of that injury. So history plays a vital role over here. And with history, I expect you to understand and not just simply have, oh, my shoulder is injured. No, it doesn't work that way. I want you all to understand why it has happened, what caused it, what is the cause for it, what added to the problems, what are the risk factors, and what you could do in the future. When it comes to a custom tailored program or a prehab or a rehab, this is what matters. When you say that you have a shoulder problem, I will tell you what the problem is, that is the cause of the problem. And at the same time, I will tell you there are 10 things which will add fuel to the fire to that shoulder problem. So if you don't take care of those 10 things, you are at risk that, the problem will come back after say 6 months or say 1 year. But if you take care of those 10 things, then you have less chances of getting back into that point. Increased use of hand paddles. Also, the surface area adds more to the drag forces, and more the drag force and more the volume of the training, more chances of you getting a shoulder strain. This doesn't mean that you should tell your coaches, please, Yash has told me that, drag paddles have a high risk. No, you need to do, obviously everything is in moderation over here. I'm not saying that you should not use hand paddles. but you should. But then obviously these are risk factors which can be managed with a good amount of strategy and moderation in terms of training volume. Now, essentially, okay, there are different kind of strokes primarily, and I'm not going to get into detail of each stroke because it's beyond the capacity of this forum for us to discuss each and every stroke in detail and get into the biomechanics. Essentially, I'm going to focus on the primary freestyle stroke. So this is basically, if you see over here on the screen, these are the phases of biomechanics, essentially, of a freestyle stroke. So figure one over here, 1A and 1B. 1A is basically when you view yourself from the front, and 1B basically is when you view yourself from the side. It's the hand entry. Over here, what I want you to see is the hand is internally rotated. Internally, it's rotated towards midline over here. So, and then into the reach, there is a bit of body roll. So over here, I want you to understand if your thoracic mobility, if your lumbar mobility, the lumbar and the thoracic mobility is restricted, then you have a reduction in the body roll over here, which will be compensated by the shoulder over here. And if the body roll is not ideal over here, the shoulder will take more of hammering in terms of cutting the water. And obviously, speed is of the essence. You want to cut through the water at the fastest pace possible. So a lot of undue forces will start happening at the shoulder, which you will not realize at that particular moment, but it adds up. It builds gradually. So this roll is also very important. Then pull through phase, once the entry into the water, when you're cutting through the water, there is a lot of internal rotation. This is where you feel the maximum resistance through the water because you're cutting it. And this is the recovery phase where the elbow is directly above the water, and this is where essentially your coaches tell that the angle should be right. So if I have to tell you that which is the most risk based stroke and phase in terms of shoulder injury, it's 3A, 3B, 3 and 4. Maximum chances of you developing a shoulder problem happens at the pull through phase and the recovery phase. The reach is fine, the hand entry is also good, but in compared to the pull through and recovery is also one of, because that is where you get the maximal end range. You get into the shoulder end range, maximum available range, and that is where the pinching happens. So out of the four phases, 3 and 4 maximum chances of you getting the injury, and out of 3 and 4 is the number one risk factors in terms of, if this technique is not right, if the body roll doesn't happen properly at figure 4, then again the pinching happens at the shoulder. So why am I explaining you all this? So if you say that, I develop pain over the shoulder, I will go back to the coach. I will take a video. I would want to understand what happened. What is your swimming? If the roll also is not happening, if the core is not strong, if you are not cutting through the water in a streamlined fashion, then you are risking this. I cannot singularly treat your shoulder without taking care or considering these very, very important points. So now there is going to be a small video. I hope you all understand, and please, Vijay, if somebody is not able to hear, just unmute yourself and let me know that it's audible. It's got a video and an audio to itself. I hope everybody is able to listen to it. It's the shoulder rotator cuff anatomy and function.
Hi, this is Peter from Anatomy Zone, and in this tutorial, we're going to take a look at the anatomy of the rotator cuff. The rotator cuff are a group of 4 small muscles within the shoulder, which originate from the scapula and attach to the humerus to provide dynamic stability at the glenohumeral or shoulder joint. These muscles are found deep within the shoulder. So here you can see the pectoralis major, deltoid, trapezius, and latissimus dorsi muscle, which are some of the large muscles involved in moving our shoulder. Underneath these, we can find the rotator cuff muscles. So our shoulder joint is made up of the head of the humerus, which sits within the shallow glenoid fossa. At any one time, there is only about 1/3 of that humeral head sitting in the glenoid fossa. This configuration allows lots of mobility of the joint, but in return, the shoulder joint sacrifices stability. To regain stability, we have 4 rotator cuff muscles, which can be remembered by the acronym SITS: Supraspinatus, Infraspinatus, Teres minor, and on the anterior surface of the scapula, the Subscapularis. In this tutorial, we'll discuss each one of these muscles in turn. The supraspinatus originates in the supraspinous fossa. As with many anatomical terms, the name of the muscle itself gives you a clue about where it's located. Supra refers to above, and spinatus refers to the spine of the scapula. So the supraspinatus sits in the supraspinous fossa above the spine of the scapula. The supraspinatus then passes underneath the acromion to attach onto the greater tuberosity on its superior facet. In terms of its action, the supraspinatus muscle in isolation creates abduction of the humerus. The muscle is innervated by the suprascapular nerve. The next muscle is the infraspinatus, so from its name we can tell that it's located below the spine of the scapula. And it sits within the infraspinous fossa. The infraspinatus muscle inserts onto the greater tuberosity of the humerus on its middle facet, just below the insertion of the supraspinatus muscle. In isolation, the infraspinatus muscle performs lateral rotation or external rotation of the humerus. It's worth noting that the supraspinatus and infraspinatus share a nerve supply derived from the suprascapular nerve, which comes off the superior trunk of the brachial plexus to supply both of these muscles. Next, we have the teres minor muscle. The teres minor muscle is located just inferior to the infraspinatus on the lateral border of the scapula. It then inserts onto the greater tuberosity of the humerus on its inferior facet. So just to recap, we've looked at 3 rotator cuff muscles so far: the supraspinatus, infraspinatus, and teres minor, which all insert onto the greater tuberosity on the superior, middle, and inferior facets respectively. In isolation, the teres minor muscle performs external or lateral rotation of the humerus. The nerve supply to the teres minor muscle is derived from the axillary nerve. The final muscle to talk about is the subscapularis. The subscapularis muscle sits on the anterior surface of the scapula. If we now remove the rib cage, we can take a closer look at this muscle. The subscapularis originates in the subscapular fossa, which is this depression occupying almost all of the anterior part of the scapula. From its origin on the scapula, the subscapularis muscle inserts onto the lesser tuberosity of the humerus, which you can see here. The subscapularis is the largest and strongest rotator cuff muscle, accounting for approximately 50% of the cuff strength output. When you isolate this muscle, it performs medial or internal rotation of the humerus. The subscapularis is innervated by the subscapular nerves, which is comprised of the upper subscapular nerve and the lower subscapular nerve. Both these nerves originate from the posterior cord, the brachial plexus. So that's an overview of the basic anatomy of the rotator cuff muscles. Just to finish off this tutorial, I would like to go through a few clinically relevant points relating to this muscle group. We've described the individual movements of the rotator cuff when each muscle is in isolation. However, in reality, the rotator cuff muscle works as a collective unit to provide dynamic stability at our shoulder joint while we're moving our arm. So when you're thinking about describing the action of this group of muscles, they in essence keep the head of the humerus in contact with the glenoid fossa during movement. They work to provide compression and depression of the humeral head at this joint. Because of the complexity of the shoulder joint and the relative weakness of this group of muscles, they are easily injured. There are many injuries which involve this group of muscles, which are commonly referred to as rotator cuff syndrome. This essentially is an umbrella term which refers to a variety of conditions affecting the rotator cuff. Sometimes this might be an acute strain or tear of the rotator cuff, tendonitis, which is common in younger athletes. So in sports which require repetitive overhead movements like bowling in cricket or pitching in baseball, certain occupations like painting and decorating, where there's a lot of overhead arm use, can also predispose to tears of the rotator cuff, the commonest of which would be a supraspinatus tear. The reason this is the most commonly torn is because if you look here at the acromion, which is essentially like a roof above the supraspinatus tendon as it passes underneath to insert onto the greater tuberosity of the humerus, when you elevate your arm, this space narrows, meaning it can get pinched, inflamed, and consequently tear. In middle age and onwards, the blood supply, which is already poor to this muscle group, can deteriorate even further, meaning chronic overhead use of years causes a degenerative tear, which can be thought of kind of like how an old rope frays over time. And so again, the supraspinatus is often most vulnerable to this injury, and both of these would present with pain and reduced power with abduction of the shoulder. Whilst there are several others, the other common conditions you might hear talked about is subacromial impingement syndrome. This condition relates to problems arising within this area here called the subacromial space. Common pathologies in this area include supraspinatus tendonitis from overuse or a subacromial bursitis. This here is the subacromial bursa. A bursa is just a fluid-filled sac. They reduce friction between surfaces, and we have many of them throughout the body which serve the same purpose. So in either of these conditions, what is happening is that because the supraspinatus tendon is inflamed, or the bursa is inflamed, it creates a narrowing of the subacromial space, meaning that when we elevate our arm, the inflamed structure, the tendon or the bursa, gets pinched, and this causes pain. Sometimes neither of these pathologies are the cause of pain, and it can be small bony spurs projecting off the acromion, which pinches the bursa or tendon below it. The hallmark feature of this condition is the painful arc, where maximal pain is felt between 60 and 120 degrees of abduction. The pain is worst at this range because this is where the subacromial space is most narrow. But as any physiotherapist will tell you, a lot of shoulder injuries require rehabilitation of the entire rotator cuff, particularly in something like impingement syndrome, as strengthening the cuff means the humeral head will be better compressed and depressed against the glenoid, so you can get more clearance between the humerus and acromion during movement of your arm. So I hope that this tutorial has given you a good overall understanding of the anatomy of the rotator cuff. If you've enjoyed this tutorial, please give us a thumbs up, don't forget to subscribe, and we'll see you in the next tutorial.
Hi. So I hope that video was helpful in terms of you all understanding the biomechanics and the anatomy of shoulder, and what essentially happens to in the condition such as swimmer's shoulder. Swimmer's shoulder basically is the second part of the video in terms of condition what they have described, the impingement of the acromion. That is essentially swimmer's shoulder, and rotator cuff syndrome is the imbalance of those four muscles, six muscles: subscapularis, infraspinatus, supraspinatus, and teres. So those mechanics, if you would have understood, you will realize that swimming is an overhead sport. You are doing just like bowling, just like pitching a baseball ball. Swimming is an overhead sport. Basically, you just in the prone lying position, but then most of the activity of the shoulder happens in that overhead position, and that is where the impingement happens. So if your dynamic stabilizers, the rotator cuff muscles, if they are not functioning well and if they are not well balanced, then something will overwork and something will not work as much as it should. And that will cause a lot of inflammation. Either the inflammation could be because if it is constantly being used, it will get inflamed because there is a lot of micro trauma, or the other factor is there are certain degenerative changes like certain osteophytes, which was this they described in the video, that will reduce the space. So essentially it's the space which we need to maintain over here in that shoulder. So space, if the shoulder, if it's maintained, then no matter how much range is there and in what deep kind of a range you get into, it will not hurt. But there are two possibilities where that narrowing happens. Either the muscle itself gets inflamed, or because of certain areas, the bony everything, that the whole tunnel basically reduces in size, and that causes a lot of friction, which causes issues over the shoulder. So let's just get deeper into these two injuries. So swimmer's shoulder over here, if you see, is basically what the video also described. It's a subacromial impingement. Now this is your acromion over here, if you can see the arrow, and this is the coracoid. So basically this is the bridge, and then underneath this bridge are these tendons. So if this bridge reduces, this tunnel basically over here underneath this bridge, if this reduces in size because of this inflammation, or because of certain factors like the bone has grown, there is a lot of osteophytes, there's a bony outgrowth, then it will irritate this. Either it will irritate the bursa, or it will irritate the muscle, the tendon, and which will cause issues. So mechanical impingement of supraspinatus, which is this supraspinatus, this muscle, which you can see, which is directly under that bridge, and head of biceps tendons as they pass under. And this is the biceps. So biceps is also a key factor over here. And the part of the bicep goes through the capsule basically, which also helps in terms of stability of the shoulder. That's a different topic. There's something called as a labrum, which acts like a suction cuff, because the ball essentially of the joint, shoulder joint, is larger in size than in compared to the glenoid, which is this part basically over here, which is smaller in size. So to maintain that concavity, there is an additional structure. There was some sort of disturbance. I hope everybody is able to hear me. Okay, so moving forward. Yeah, so to increase that concavity, there is something called as a labrum, this white part. You can think of it, it's not the labrum, but it's what looks like that. So that improves the amount of stability you will get over the shoulder. And this blue thing over here is the bursa. So either that can get inflamed, this tendon can get inflamed, anything can happen, especially when you get into the end range, when you know that phase which we discussed early on in freestyle, that when you're trying to, in the recovery phase, this is where the pinching happens, like that. Now over here, if you closely look at this phase, so figure 4, left arm in the catch position, full forward elevation. The force of the water acts over the long lever of the arm, producing significant torque into further shoulder flexion, resulting position of impingement over here. So as soon as the hand is inside the water, you start internally rotating, and that puts forces over here. In figure 5 over here, basically, this left arm early pull phase still in a high degree of elevation with increased internal rotation. So obviously now you're slowly getting into the phase where you have to cut through the water and propel yourself forwards. So this is where further internal rotation happens. And figure 6 over here is left arm in the early recovery phase. The shoulder is in abduction and internal rotation. This is the maximum position where the maximum pinching is happening. Maximum end range movement. That is what we clinically call it as. It's the end range movement. This and this. Figure 5 and figure 6 are the main areas where there are maximum forces happening at the shoulder. There are chances that it's getting pinched over and over and over again. So that is where the volume of your training matters. It might not have any deep impact on day 1, but at day 99, you might have some sort of an issue because you've been doing that day in and out. So volume of the training is very, very important factor in making sure that these kind of things don't happen. Now, these are certain imaging. So when people like me hold an MRI on the hand and y'all are clueless in terms of what to look and how can we even understand something out of these black and white images. So I will just try to explain you what we essentially look at over here. So over here in this diagram 14 A and B, this blue arrow over here is the one of the muscles, rotator cuff muscle, two muscles basically, subscapularis and supraspinatus. So essentially this is the position of this in this manner. So if I keep my shoulder in this position, or for that matter this position, this is where the locking happens. You can't go beyond this. So when this locking happens, it pinches. So this blue arrow over here, which you see, are the points where the pinching is happening and the two rotator cuff muscles are getting inflamed. So this hazy white spot over here and this over here are the area. So this is what we look at the film and understand, oh, this is where the pinching is happening and this is where the trauma over the soft tissue has happened. Over here on figure 15 is the actual tendon and the labrum. This basically, someone's mic is on. Can you please?
I muted it. Go ahead.
Yeah. So this green arrow over here is the labrum. Labrum, which I was trying to explain you, that improves the concavity of the shoulder joint, which helps in stability of the shoulder. So this is that part over here, the green arrow, and the blue part is the actual tendon. So rotator cuff. So this is the image, or this is how an arthroscopic surgeon does a surgery through inserting a camera, and this is what the actual muscle or the tendon looks like in reality. Now, rotator cuff injuries. So impingement or the swimmer shoulder, I've tried to explain you what the mechanics and what the pathomechanics is. The other thing is rotator cuff. So rotator cuff, again, it's a very complex process in terms of me coming to a conclusion that this muscle is affected to this extent. We say that it's a grade 2, grade 1, grade 3 say tear or whatever. So there is a lot of processing which we have to done, and there are a lot of factors which we have to look into in terms of understanding what has happened. So over here, if you see this flow chart, rotator cuff tendinopathy. Basically, if there is any issue with the rotator cuff tendon. So what are the causes? It could be extrinsic, something happening from the external aspect, outside, and intrinsic, something happening from within, from my own body. External originates like compression, shear force, even your training volume can be considered as an extrinsic factor. Obviously, it swings between internal and external. Intrinsic would be degenerative process potentially associated with aging. Again, we are all young, the recovery rate is fine, but again, overuse over here is the key. The volume decides the intrinsic mechanism and the extrinsic mechanism. Sorry. Now, if extrinsic factors, there are impingement happening. There are two divisions basically. Subacromial, I told you, is the bridge, and internal impingement happens near the fossa, basically where that ball and socket joint is. So there could be several reasons why it could happen. It could be a bony outgrowth like a spur, or the shape, basically the anatomy of that, or if again there is a spur. So these are biomechanical or anatomical factors which you as an individually don't have any control on. It's just anatomy, basically. Degeneration happens to all of us. So you can't have control over such things, basically. Then intrinsic factors, tendon vascularity. So every muscle and the structures basically in human body are innervated by blood vessels. They need blood. Just like, we have blood circulates throughout the body, and each and every muscle in the body has some vascular supply. So if there are certain areas in those muscles, rotator cuff, which are not as vascular as the other part. So those areas where the blood supply is minimal have a high risk of getting injured. Plus, they don't recover in time because blood basically supplies your nutrients for wear and tear and repair. So if the blood supply is restricted, then obviously the recovery will get compromised. So areas where there is minimal amount of blood supply on those tendons have a high chances of getting worn out and tearing. Tendon biology, I mean, these are physiological considerations which I would not expect you all to understand, but these also play an important role. Collagen content all depends upon the healing, the rate of recovery, and the rate at which the tissues are getting damaged. It needs to have that fine balance. Usually an overuse injury happens in simple terms is when the rate at which the tissue is getting destroyed is much faster or higher than the rate at which the body is healing itself. Body heals itself every day in and out. When you are sleeping, your body is trying to heal itself, and that is when you wake up on the next day, you feel fresh. So repairing happens during that time. So if that fine balance is not happening, then obviously it leads to injury, chronic injury. Tendon morphology, thickness, irregularity. I told you, if there is inflammation of the tendon, then obviously it's going to have more amount of friction. More amount of friction, it leads to more problems. Now, genetic factor, again, it's debatable over here. The other important key aspects over which you need to know is the scapular kinematics. So scapula is the triangle bone which you would have seen in the video. If the mechanics are not ideal, then it could have an impact. Right now, the research says, earlier the research says that if the scapular movement is not proper, then it has a direct impact on the injury. But now the research says that it may or may not have. It is not as significant as it looked back then. But obviously, we need to work on those scapular dynamics also. And out of those 4 rotator cuff muscles, what has come out of research is that supraspinatus is one muscle which is maximally injured. So ideally, you would think that if your supraspinatus rotator cuff muscle, if it is injured, then that is the main cause. Out of all those 4 muscles, that is the main. No. For you, research says that subscapularis is the key muscle. In the video, you said that it generates 50% of your internal rotation force. So people, swimmers especially, have had a very negative impact on their swimming training because of subscapularis and not supraspinatus. And this was a research done in Australia on Australian swimmers. So that research says that subscapularis is a key muscle over supraspinatus, although the supraspinatus, the occurrence rate is much higher. But if the subscapularis fails, then that is a lead cause of the swimmer not being able to participate. So over here, a simple diagrammatic representation. These are the normal tendons, nothing over here. And then this area over here where you can see there's a lot of these red spots, inflammation is happening. And that is because of the wear and tear, overuse, repetitive movements, your body not being able to recover in the way it should be. So this is what happens. Now this slide basically, this is what we do. So if some swimmer, one of you comes to me and asks me, okay, I have shoulder pain. So this is a flowchart in terms of what we do from that point when you tell me I have a shoulder pain to a point where you say I'm absolutely fine. Those exercises help me really well. So when you come, obviously we ask this is a flowchart in terms of how we go about the assessment, and we come to a conclusion of what the problem is of the shoulder pain. When you come, obviously we take care in terms of understanding what caused it, how bad is it, what is the severity. We also ask you a lot of questions in terms of understanding what was the mechanism, because mechanism is something which will give me a lot of information. If you say I have pain in this movement, it's when I'm getting my hand inside the water is more troublesome than when I'm trying to pull out, then it gives me a different set of ideas. But when you tell me when I'm trying to take my hand off, once I've already cut through the water, at the end when I'm taking the hand off, that is when I have pain. That makes me think in a different direction altogether. So that is why we ask so many detailed questions. Then so over here is the clinical functional assessment. Once you all have given us the details, we do certain clinical tests as clinicians in terms of making sure that we have hit the nail, we've hit bullseye, and we also call it as a provocative test. That is when we try to get the pain back in terms of understanding, okay, we are hitting the right structure. So we do certain tests, we ask you to move the shoulder in certain manner. Those are the movements in which there is maximum chances I'm putting the load on that structure. So that gives me a confirmation. Yes, okay, this is the structure which is finally involved, and this is the structure which needs to be dealt with. And as I initially told you all, that is, I'm not going to stop there. I will also ask this question to why that happened. Why did that structure get injured in the first place? So there would be 5 to 10 reasons why it would have happened. It could be because they are not working in synchrony. It could be because you have reduced amount of mobility over your thoracic cage. It could be because your movement over the neck is not proper. It could be because your core is weak and you are inside the water. That increases the drag force. So there are multiple things which we will further get into, deep dive into, in terms of understanding that, okay, this problem has happened. What could lead to, or what are the predisposing factors clinically, what we say. Then we will go to the coach. We will try to understand the stroke mechanics, discuss with the coaches, understand this is what is happening, that is what is happening. Maybe we can do this. Maybe so the coach will give their inputs. They will explain us, oh, this is what is happening, and this week, this is what we need to do. These are my suggestions. After considering all that, if at all, if we need, we finally get an X-ray or an MRI or an investigation done. And that will further confirm what the problem is. After that, we give you a program in terms of rehabilitation or certain exercise which you need to do, which you all have to follow. And when I say you have to follow, that becomes your bread and butter. Why? Is because what was rehab as of now, once you have recovered completely, will become rehab. Those are the essential things you need to take care of, because you already know that has happened in the past. So if you don't take care of those things, what has already occurred in the past, you have a high risk of getting back into that same situation. So rehab translates into your prehab once you are absolutely fit, then back into the game. So do not feel that, oh, I'm fine, pain free, and I have nothing to do, and wait for another episode to come back and give you the same sort of problem. So you need to be ahead of the game. You need to think it through. Now, obviously, we have periodic assessments which we've discussed early on, that MSK screening in terms of the injury prevention seminar which I had taken earlier. This is where the reassessment comes into play. This is where we go back and say, okay, this athlete has injury in terms of previous history of the shoulder. So we need to look into it and make sure that everything is running smoothly. So those periodic assessments and reassessments are very, very vital. And ultimately, then we come out to the conclusion that everything is fine and this was the shoulder pain. So this is how we go about, and this is how the shoulder essentially in your swimming profession gets affected. And these are the factors. Again, obviously, it's a very vast topic, but I've tried to help you understand what are the mechanics.
Yash, you're not audible, please. Just 1 second. Can you try now?
Am I audible now?
Yeah, much better.
Yeah. So basically, this is what I've tried to explain over here in a very simple manner. Obviously, this is a very vast topic. I cannot, we can go on for like the whole year and it's still not going to end. But in a nutshell, I've tried to explain you what happens and what are the primary cause of shoulder injuries in swimming and what are the mechanics. So now you can relate. Now, since you all have seen the videos, you understand the anatomy, maybe you all can relate to it in a much better way. So that was my whole intention of having this kind of a presentation for you all. So I'm open to questions now. Thank you.
Questions for Yash?
If there are any questions, please let me know.
If there are no questions, then we'll end for today. Probably, if people have questions, they can reach out to you. Oh yeah, there's a question.
There's a question over here. Since our kids are doing long hours of swimming, is there any precaution to take after swim? Yes, definitely. That is why we are emphasizing a lot on cool down and cool down protocols. You need to stretch. You need to stretch those muscles. You need to relax those joints which have taken so much of loading. You need to get back in terms of getting those nutrients, flushing your body with a lot of nutrients in terms of the recovery drinks which your nutritionist might have prescribed. So there is tons and tons of things which the athlete should do after the session. Does lack of proper sleep lead to injury? Yes, the research says that if the sleep pattern is affected, then you are at a higher risk of injury. So sleep is absolutely essential. And an ideally 7.5 hours to 8 hours sleep is quite essential. It also depends on the kind of work these swimmers are doing. So the total volume. So I would there's definite correlation between the sleep pattern and the quality of sleep. I mean, like you would be on your bed, but are you sleeping, getting a deep sleep? So if the sleep is compromised, that is one metric which we moderate on a daily basis for our swimmers. We ask them the quality of their sleep, and it gives us a lot of information about how they have recovered in the time. Again, after the workouts, again in acute phase, cold pack, never heat. If you are doing anything within 24 hours, if you've worked hard, if you've pushed yourself in terms of physical exertion, the best way to recover is ice. Cryotherapy is the best way, not hot. Can you please explain age-based injuries? Example 9 to 12, 12 to 15, 15 to 18. So age-based injuries, again, it depends a lot on the growth. So 9 to 12, 12 to 15 are the ages where the growth period is maximum. So there is something called as an adolescent athlete, where the people are growing, women, female and male are growing at a similar rate, but female tend to grow and reach their growth spurts much earlier in comparison to males, and that has a huge impact on injuries as well. So there are certain ways in which we are managing. Obviously, certain sports, and swimming essentially starts at a very early age. The other sport which I can come across is ballet, which wherein the athlete has to start in at a very early age. So there are certain considerations, and we are so the dryland program basically has a lot of impact in terms of making sure that the injuries are managed in terms of different age groups. So at 9 to 12, I would want work more on the skill development. I would want the athlete to learn the technique. 12 to 15 is once when you have actually learned the technique, you start developing further refinement in terms of your movements, and your actual loading happens at 15 to 18. So if you follow this flow and if you follow this understanding, you have minimal risk of getting injured. Usually what happens at 9 to 10, 9 to 12 only, people are hammering everybody to their core, and by the time they reach 15 or 18, they are exhausted. So age and injury has a definite correlation, but the agenda or how we go about the approach for a younger athlete and somebody who's 18-year-old is very different. Mr. Rajesh, out of all four strokes, whether breaststroke and backstroke are least prone to? No, again, so every stroke has its own biomechanical considerations to taken care of. We cannot say which is maximally involved or minimally involved. And what you need to understand over here is common is freestyle. Freestyle is a common stroke, basically, which is a part of the swimmer's workout on an early day. So that is because it is commonly used. That is when the risk or the occurrence of injuries in that stroke is more. But every other stroke has its own biomechanical considerations, so we cannot have that comparison, which is more and which is less. Yes, I think cryotherapy in essence helps. There are cryotherapy chambers. If you feel that your shoulder has been worked heavily, have an ice bag, put an ice bag. It will help in terms of recovery. Icing always helps immediately post workouts. I had shoulder pain last year. Do I still need to additional rehab exercises? Again, I will not call it as rehab. I would call it as prehab. You already know that there are certain issues in your shoulder. Now you need to make sure that all those things have been taken care of and they are not still continuing, and you need to make sure that you don't go back into that state. Sukanya Bharat. So yes, you need to have a custom tailored program which will prevent you from getting back into that shoulder problem which you had in the past. I had shoulder. Okay. Which is the most risky stroke? Again, we cannot say risky stroke because there is nothing risky. You got to do what you got to do. If you're a breaststroker and if you are a backstroker, you need to do what you're expected to do. There is no risk. Risk is everywhere. I mean, like right now, if I'm talking to you, also there is a risk something can happen. So risk is not something which you have to deal with. There is no risk, high risk. There are certain considerations which you need to have in mind. You need to understand your body well. You need to have a well planned program in front of you. And if you follow everything in moderation with good amount of scientific and data approach, then obviously things will be less prone in terms of injury. Long hours of training in dry land. Could you please suggest some precautionary measures? That is when we come across as, so Miss Neha, This is Neha. Since the sport is demanding, involving long hours of training along with dry land, could you please suggest some precautionary measures? This is where we give certain custom tailored workouts to that athlete. Once we have a MSK screening program done, once we completely evaluate that athlete, we know these are the problems, or these, not, I would not say problems, sorry, that's the wrong terminology over here. I would say these are the risk factors. These could be the probable cause for an injury in future. Once we do those MSK screenings, we understand what needs to be worked on and what is absolutely fine. So after that, we will give you a custom tailored program, and that needs to be followed. And if you follow that, you have less chances of getting injured. That is the whole idea behind having these periodic assessments, is to find your weakest link. It's very simple. You are only as strong as your weakest link, and if you can understand what your weakest link is early on and work on it, you have high chances of winning more medals and being at lower risk of getting injured. Thank you. I hope everybody gained something out of it. Thank you.